No, it's a junior, junior semester. We're going to just cover a brief EKG overview, just a refresher on something. It's a little bit different from the way we do it in the emergency department. I'll kind of explain. We're not reading every EKG like you learned in the EKG course, but we're looking for some more significant findings that are concerning, because in the ER we worry about, death or things that are going to kill our patient the quickest. But before that, we'll do a little check on learning. So let's take a look. Good old chest X-ray. And it's important. This is the most ordered image in the country, at least, maybe probably the world. You guys will read lots of these. What do we see? Other than like a poor pixelated image. Oop, wrong one.
There's a lot of air in the left side.
Would we say it's normal?
No.
All right, good. We can agree on that. Good, good. We're going on the right track. So what do we see on there? Somebody.
Pneumothorax.
Yeah, we got left side pneumothorax. And, we touch on there how to measure and all that. We really just look at it like, is it small or not small, or is it huge? Is everything, there's no lung in there. So this is kind of in between, right? This is like, not small. Do you guys think there's a mediastinal shift on there? Yeah, it looks like it's shifting a little bit, right? So let's say the patient, is presents with this and shortness of breath, but vital signs are stable. What are we going to do treatment-wise?
Needle.
Yeah, likely getting a chest tube, right? What can we do first? Some oxygen, yeah. But so the vital signs are stable. Do we need to go to a needle decompression? No, we probably don't, right? He's stable. So we can take a little bit of time and look at possibly getting some oxygen and preparing for a tube thoracostomy. What if they're unstable? Then we're going to do the tube. All right. What if let's say it's a little bit smaller than this? What's our treatment? Let's say it's a small 2 centimeters. Oxygen, observe them for 4 to 6 hours, and then if we see resolution, we'll admit them. Good. Good, good. All right, let's talk about EKGs. And here's the approach. What's the rate, rhythm? Looking at my intervals, morphology, axis, is there hypertrophy, ischemia, infarction? And we do it a little bit differently in the ER, so we look at it like, is it too fast? Is it too slow? Is it regular? Is it, is the QRS wide or narrow? And then we look for deadly arrhythmias or signs of ischemia or infarction is what we're looking for in the ER. And we'll just cover a couple quick things like, so too fast, too slow. I know you guys learned it's 10 seconds. You can count all the QRSs across there, or the R-to-R intervals. We use, I use this method, and it's really one of the, one box, 300. I just line up one of the R's, and I do look at 300, 150, 175, 60, and then I roughly estimate it from there. Like, okay, maybe it's like 70-ish. It's a little bit below that tick mark line. And you can do it a lot of different ways, but for us, we're really worried about is it too fast or too slow, and then what do we got to do? What else do we have to look at in order to fix that? This was on the slide. I only leave it there to make fun of it. Like, I don't even know what they're trying to do. Like, this is somebody who must be like wicked smart or some beautiful mind stuff with all this math going on there, just to come up with 70 beats a minute. But this is another method you can use by actually using however many seconds or seconds or milliseconds, however you want to talk about it, and then coming up with your rate as well. But really, I just use, count those boxes and decide, like, is it fast or slow, or is it within that normal range? And then I move on to what the rhythm looks like. So is it regular or irregular? Something we always want to know, because then we can stratify in different categories. If it's irregular, we know it can only be, a few, well, it can be more than a few different things, but a few different things that are concerning that we are looking for in the emergency setting that could be a deadly arrhythmia that could cause some problems for this patient. And then we look at the QRS morphology. Is it narrow, wide, And then the relationship, is there a P before every QRS? So pretty basic, hopefully it's all coming back to you guys. And then here's our different intervals. We won't, get into too much other than, we just look at like that PR interval. So there are, is it regular? Like, is it within that 0.122? And then if it's not, is it shortened? So that puts in the category like, is it a WPW, an LGL, junctional rhythm? Or is it longer, and then we start looking at heart blocks. So we move on to our QRS interval. Is it wide or narrow? If it's wide, then we can start thinking there might be some bundle branch blocks. It might be like a ventricular tachycardia or a ventricular rhythm. Is this from drugs? Then we have our QTC interval, which we care about over 500 seconds. So really when we look at it grossly, we look at that QT, we go from like the R to R, and as long as that QT is like less than half the distance between the R to R, in our minds roughly, we're like, okay, it's probably close to the normal range. That's not concerning. If it's longer than half that distance, it's probably over 500, and that's when it becomes clinically significant for like the QT prolongation. And then we think about some of the arrhythmias at that point. For what we're covering today, we're covering mostly ACS, so it's going to be a lot of ST elevation, depression, and things related to that. And then here's our morphology. So we have our P wave morphology. So is it that peaked P wave, the P pulmonale? And then we have, is it widened? So P mitral, is it a wide P wave? And then we look at our QRS. When it's widened, like, are we concerned for some sort of bundle branch block? And you can see on the right side, we have the top one, which is going to be your right bundle branch block, and the left one, it's going to be, or the bottom one's going to be your left bundle branch block. But we won't get too crazy in depth with those. Here's what we're more focused on today is we're looking at T waves, and we're looking for ischemia and infarction. And it's important because, a lot of you guys probably look at it right now and you're like, man, all those T waves look the same. I don't even know what you're talking about. But this is kind of how it changes when we have ischemia, infarction, or some sort of non-specific ST, T wave abnormality, which is a very common thing we see. What's important is just looking at that morphology of the T wave. So when you start to get like an increased size in those T waves, we call them hyperacute T waves, and that could be a sign of ischemia or pending infarction. And it may not have manifested yet. We have our, those peak T waves that we see with hyperkalemia. So all of this can kind of help guide us on the EKG, what we think it is, and depending on which leads, which we'll cover next. Axis deviation, I'm not going to ask you guys what axis this is on there, but it's important to like kind of conceptualize it when you think about where that, wherever they took the hit in the heart. So like, or whatever the abnormality, if they have hypertrophy, you may see your axis swing towards it, infarction away from it. And we can kind of match it to this when we're looking at the EKG to say, okay, that makes sense with what pathology I have, whether it's, whether it's, it's affecting the left anterior descending artery, and I have the ST elevation and right axis deviation. So these are all just little cues to help us. I don't expect you to be experts on EKGs, but I do expect you to know like ST elevation, depression, and which leads are associated with certain arteries or infarctions. Then we have our hypertrophies, and you have commonly LVH, RVH. LVH, I think it's actually a lot more LVH probably than right ventricular hypertrophy, but really it's just, you can usually grossly see it on an EKG when you see that giant S wave in V1, and then you can look at V5 or 6, and if it's over 35 millimeters, it's left ventricular hypertrophy. And it is a little bit different grading for right ventricular hypertrophy, so it's the R greater than the S of V1, and S greater, and it reverses for V6. All right, so here's what we're mainly concerned with today. It's going to be, ischemia and infarction. So for infarction, we expect that ST elevation. Ischemia is going to cause an ST depression, which could be concerning for a pending infarction or ischemia that we need to do something about. And there's different morphologies, which some pictures will be better than me trying to explain it. So here's the evolution of an MI and why you see that ST elevation, which then as it infarcts, it turns into a Q wave, and that ST, or the T wave doesn't always come back to the normal height that it would have, or normally where it's not elevated anymore. But for the evolution, you start to get what we call hyperacute T waves or peak T waves, followed by some sort of degree of elevation in there. And it's usually not like a smooth, even contour or symmetric contour when we're looking at that ST segment. And it looks like these pictures, how they're kind of funky, sloped. The one on the right's extremely elevated. And then as it infarcts, it then progresses to that Q wave, velocity R wave, followed by the Q wave, and T wave inversion. But here's what's important to remember is which leads are associated with certain ST elevation or pathology that we're going to talk about in the next lecture. So you got your inferior, so that's 2-3 AVF. You got your lateral, which is going to be 1 AVL, V5, V6. You have your anterior and septal, so usually septal will say like V1, 2, and then anterior V3, 4. And then I think that's all of them on there. What's important to remember is which arteries are associated with this. Like your lateral leads, you'll have your left circumflex. Inferior, we worry about the RCA. Mostly, it could also be the left circumflex, and we worry about that left anterior descending, which is one of our concerning findings for ischemia because it has our highest mortality rate. And then here's just another picture of which areas of infarction may cause those elevations on there that you see on the EKG. And then STEMI, so that's what we're talking about today, mostly STEMI. You guys remember the Pale's algorithm? If it's, posterior look anterior, anterior look inferior, inferior look lateral, lateral look septal. So that's important to just consider when we're looking for reciprocal changes on those. So if we have ST elevation and our like anterior leads, we want to look inferior. So you see elevation in like 2, 3, 4. You want to look for inferior depression in that like 2, 3 in AVF. All right. Let's look at a couple of these. What do we see on here? Yeah. So we got ST elevation. What kind of STEMI do we think this is? Inferior, posterior, lateral?
Lateral.
Yeah, it looks like lateral, right? So you have that elevation, 1 in AVL. We got depression or reciprocal changes in 3 and 4. Arguably, there's a little depression in 2. And then, let's see what it is. It's a lateral, good. So what artery is commonly involved with this, or may be involved with this? Yeah, left circumflex, good. What do we see on this one?
Inferior.
Yeah, inferior. I'd agree. And are there, for these ones, is there another EKG we can get with this? Yeah, we'll get a right ventricular, or right side leads, or we get a V4R. Good. All right. It's pretty small. And this is just showing, what it looks like when you get your right-sided leads. That's a right ventricular infarct. Good. So here's similar, less prominent on here, but this is going to be your posterior, and we'll talk about how we kind of identify some of those in the next lecture. What do we see on this one?
Psychedelic.
You guys see like anterior septal. So this is concerning for which artery?
The lad.
Yeah, the lad, so the left anterior descending. Yeah, good. What about, do we see reciprocal changes on here? Yeah, I don't really see anything on there. Good, what about this one?
Anterior.
one's a little bit more subtle. But yeah,
Just a little
similar,
bump.
yeah, similar to the last one, that's an anterior. And like roughly 30% of STEMIs don't have reciprocal changes. All right, that's all we're covering on that one. You guys feel like experts now?
Huh?
Right. There's Tintnolly. All right, so here's our objectives for today. So, you know, when we think of certain complaints, we have to rule out or consider certain differential diagnoses, especially like your deadly differentials that we like to call. And these are the common ones, not common, these are the deadly ones that we see with chest pain, or that we consider when we have chest pain in anybody, and that we need to ensure that we rule out with our, whether that's through history, physical exam, or ancillary testing. But those are the 6 causes that we're worried about today, and we'll mainly cover ACS in this lecture. All right. I don't know why they always had take-home points at the beginning, but I left them because, I mean, really, this is like all you need to know here. But I'm gonna give you like 3 paragraphs, and then it'll be like get an EKG within 10 minutes. You know, we like to make it a little difficult. So what we're worried about, you know, ACS encompasses, you know, your myocardial infarction, so your STEMI and your NSTEMI, and then your unstable angina. And that's what we're trying to identify here today. And our EKG can be helpful, especially with stratifying them into which category they're in, like STEMI's obvious on the EKG. And then we have to look at some ancillary testing with like our labs for NSTEMI. And then we'll talk about unstable angina and how that presents. But the key here, EKG within 10 minutes of presenting to the ED is important, and it's a metric that we do nationwide if you have an emergency department. And we're looking for that ST elevation or depression, or any of the other classic findings that we'll cover here today, like our Wellen signs and other things like that. To diagnose NSTEMI, we need to get a troponin, and so we have some time frames we like to keep in mind. So if the onset's less than 6 hours, we need to get what we call a delta troponin or a repeat troponin in 2 hours. We have a lot higher sensitivity tests today, so we can sometimes use a high sensitivity in the first 2 hours, rule it out. We're not going to talk about that. And then it's important to know like our heart score, and that's how we risk stratify patients with chest pain. And we'll cover some of the percentages and metrics it looks at, but really it's whether there's any sort of acute mortality associated with ACS over the next 30 days is what that kind of risk stratifies those patients into. And then important things to remember, our door to PCI time is 90 minutes, and that's where they get a catheter and through the cardiology clinic. And then if you're not at a PCI capable facility, like you're working somewhere that doesn't have a cardiologist or a cath lab, then it's 120 minutes. We give fibrinolytics in 30 minutes. Everyone gets aspirin. Everyone gets anticoagulated that has a STEMI. And then if their vitals, or depending on if it's an inferior MI, everyone gets nitrates as well, as long as vitals dependent. But the definitive treatment is PCI. All right, so pretty common complaint in the emergency department, chest pain. You know, it says approximately 7 million a year. I think abdominal pain and some other complaints are more common than chest pain, but it's something you're going to see every day, especially working in the ER. You'll see it in your clinics as well. So it's important to know what some of the red flags are, that this is an acute coronary syndrome, and maybe I shouldn't be treating this in an outpatient clinic, or whether in the ER I need to call the cath lab. And yes, we still miss, myocardial infarctions in the ED. All right, here's our warm-up case. 78-year-old male, brought into your ED with acute chest pain, reports chest heaviness, shortness of breath for the last hour while working on the computer. EMS gave 324 milligrams of aspirin. Vital signs are 94/66, heart rate 102, respiratory 16, unlabored, pulse ox 98%. Physical exam reveals well-nourished, well-developed male, moderate stress. Here's his EKG. So the question is, what are we doing from here? That's pretty significant ST elevation in there. So, yeah.
That's normal.
Concerning for inferior myocardial infarction. So he's got his aspirin on board. We'll get oxygen on this patient, likely a nasal cannula. We'll establish our safety net. And then, we need to get some sort of anticoagulation with the STEMI. We would probably avoid nitrates in this patient because he's hypotensive. But here's what we do, we call a code STEMI is what we do in most places, and they activate the cath lab. We give fiber release if they're not at a PCI capable facility. All right, let's look at another one. 80-year-old man presents CVD with chest pain. You see this. What do we see on here? Inferior MI? ST elevation? Yeah, good. All right. So yeah, this is likely, a classic RCA lesion. Good. All right, so inferior myocardial infarction. And we kind of already identified those changes. How about this one? 65-year-old with chest pain. What's this one look like? Yeah, this one looks like an anterior. Looks probably like it's left anterior descending artery or one of its branches on there. So you've got reciprocal changes inferiorly on this one. You've got anterior elevation. All right. All right, let's talk about ACS. So it's important, we categorize these into, the correct place. So we have, or we call them correctly. So historically, acute myocardial infarction is what we call it. But it then goes into a couple different classifications, whether it's STEMI versus NSTEMI. STEMI, you have EKG changes. NSTEMI, you have no EKG changes, and you have cardiac biomarkers indicating that they're having an infarction. Acute ischemia is just, they have some sort of lesion in there, and likely new, so they might have some sort of platelet aggregation and a new clot or blockage in one of those arteries. However, it hasn't led to ischemia, or it's not completely blocking it yet, but the patient presents symptomatic, and usually with some sort of activity, it's going to cause this. All right, so you have a fixed lesion causes like exercise-induced myocardial ischemia. So when they reach a certain point, their blood can't keep up with that portion of the myocardium, and you start to become symptomatic. The other ones, when it completely occludes it, that's when we call it like acute coronary syndrome or ACS. There can be other causes for it too, like arterial spasms, just microvascular dysfunction. There can be drugs that cause this, like cocaine can cause similar symptoms too, but they don't have an actual lesion there. But in order for it to be ACS, usually that plaque ruptures and gets lodged in there, then a platelet-rich thrombus develops, and then it reduces that coronary blood flow, and then depending on the mismatch and how acute it is, what artery, we then might have, ischemia versus infarction versus unstable angina. And here's just a little picture of ischemia. You don't have complete occlusion, so you'll still have some blood getting through, but not sufficient enough oxygen or hypoxia to that area, versus infarction, which is going to be complete occlusion, then you're going to have that necrosis and cellular death. And our goal is to avoid it, avoid that necrosis before it becomes irreversible. And that's why we do a lot of the stuff we're going to talk about today. So our initial assessment, we obviously get vital signs. Most of the time for the EKG, in the ER, we get EKG within 10 minutes. So they normally get a triage right when the patient presents. We have a triage room, the nurse normally gets vitals. We'll get an EKG right then as well. It's always important to look, to pay attention to our vitals. That's why we call them vital signs. So we want to look at, for concerning findings, are they hypotensive, bradycardic, tachycardic? Is this something I have to deal with right now versus later? Then we establish our safety net in everybody. We get aspirin on board with all of these, and then we identify any other immediate life threats. All right, so it says it like 7,000 times in here. So it's probably important, like we get the EKG within 10 minutes. The goal is we get the EKG, it's read within 10 minutes, and then we decide what we're gonna do from there. We need to take into account their vital signs, but we'll cover some historical factors here that are very important for STEMI. And then we'll look at how we rule out STEMI or rule them in. And it's hard to say you ruled something out unless you've done a significant amount of testing, but we won't talk about that too much. All right, so what's our classic history for, acute coronary syndrome? That's gonna be that retrosternal crushing, squeezing, chest pain. They may describe as tightness, pressure, classically brought on by some sort of exertion. It's relieved by rest. And then we look at time frame with it. So stable angina is usually intermittent, so it lasts 2 to 10 minutes. Unstable angina is a little bit longer, 10 to 30. There's no like hard line here. And then myocardial infarction usually lasts longer than 30 minutes. Other important classic features, if they have pain radiating to their jaw, neck, or one of their arms, those are concerning findings, as well as diaphoresis, dyspnea, nausea, vomiting. And then our non-classic chest pain, which we see more frequently in like women, diabetics, elderly, is going to be, it might be like a really quick intermittent pain. They may have a constant pain. A lot of times they'll have the nausea or vomiting is sometimes their chief complaint, or maybe shortness of breath. So these are all things we need to consider when we're getting our history or HPI on whether we think we need to place them into that category of could this be ACS and do I need to do something about it. So anginal equivalents are important. I think one of the most important is if somebody's had a prior acute coronary syndrome, asking them, does this feel like your last one? And that usually, that concerns me a lot more when patients like, this feels just like my last heart attack. I'm like, oh crap, probably a STEMI and we need to do something about it. But I mean, other symptoms you see on there, which are pretty broad, so not as helpful, but they can also present with some of these, especially like that epigastric pain is something we need to consider as well. A lot, so like for me, when I look at it, because we see a lot of epigastric pain, and typically we think, could this be something with the abdominal cavity or GI related? Like, is this some sort of like GERD? Is it a pancreatitis? Is it a cholecystitis? But anybody, usually, my general rule, anybody over 40, I need to make sure I rule out ACS if they present with epigastric pain as well. So that's always something to consider in your differential diagnosis. And then for the ER, we don't ask a ton of family history unless it's going to change our management. For these ones, it might. So we always want to know, did any of their first degree relatives, did they have anybody that died of a heart attack, especially at a young age? We want to know that. All right. So yeah, we get our normal history, like the onset, OBQRST. There's another acronym that some people use for quantifying or qualifying the pain in the patient. 5 historical factors are the ones important, like that strongly suggest ACS. So they have exertional pain is an important one. Is there diaphoresis? Do they have radiation to the arms, jaw, neck, vomiting? And then does this feel like their last heart attack? So those should raise your suspicion a little bit more that this might be ACS. So like sudden onsets, we tend to think like, is this an aortic dissection, PE or pneumothorax? And so we want to rule those out as well. And then here's our risk factors for ACS. And it's important to remember these, especially when we're going to calculate what we call a heart score for patients that don't have a STEMI, and we're trying to decide what the risk is for an acute coronary syndrome in the next 30 days. So, anybody over 40, male or postmenopausal female, tobacco use, hyperlipidemia, diabetes, obesity, family history, sedentary lifestyle. So these all are CAD risk factors that can increase their chance of having an acute coronary syndrome. All right, general appearance, yeah, it can look like anything. I mean, hopefully you guys have noticed throughout it, like all my physical exam stuff, it all looks the same. Everything almost kind of looks the same. You can have, they may have tachycardia, they may not. They may have, diminished heart sounds. They may have murmur, they may not. May have edema. Some of those things can help you while you're coming up with your differential of other things to properly rule out when you're evaluating for chest pain, like might it be a heart failure or anything like that. But really, your vital signs can look like anything with any presentation, so that's why we tend to rule out a lot of things when they're in the ER, so anything that might be related to chest pain, we need to rule out ACS. So a new systolic murmur is concerning when we're evaluating these patients. So you can have papillary muscle dysfunction, ventricular septal defects, mitral valve resulting in mitral regurg. So these are important things we need to check on physical exam and see if we find any new murmurs on there, because that may help us with our prognosis or how severe this acute coronary syndrome might be. And then we need to get an EKG. So like I said, 10 minutes, we need to interpret it. So the criteria for STEMI is going to be, 1 millimeter in at least 2 contiguous leads. So that's what we're going to call a STEMI. And then they need some sort of reperfusion like PCI or fibrinolytics, depending on where you're at or what facility. If you're still concerned for ACS, first EKG is normal, then you want to repeat that every, 15 to 30 minutes. All right, so our single best test is going to be that EKG. Sometimes now EMS can run pre-hospital EKGs, which is helpful for facilities that don't have a cath lab in them. So if they can do that, great, and they can route to the right facility. Most of the time, though, they present to the ER when we get the EKG there. All right. So STEMI is based on that EKG. You have that, elevation and 2 contiguous leads. We call that a STEMI. And then NSTEMI is you're still concerned for acute coronary syndrome, so you got to get biomarkers. And if they have a positive troponin, we will call that an NSTEMI. And then unstable angina is EKG and biomarkers aren't diagnostic, but we're still concerned that it's likely some sort of lesion in there. We categorize those unstable angina. And then we look at their heart score, which we'll talk about shortly. Here's what we had on that picture earlier, which lead. It's just important, and I think you guys know it already, which leads are associated with which lesion, so I won't continue to beat that dead horse. Things to consider on the EKG, which we talked about, inferior wall MIs, we should get that right-sided EKG. And then if it's a right ventricular infarction, they're below dependent, so we don't use nitroglycerin on those, or we caution it. We don't use beta blockers for anybody in the emergent setting anymore. It will be something they'll probably get in the first 24 hours after their STEMI, but it's not something done emergently in the ER. Reciprocal changes indicate there's a larger area of injury risk, so that's why we look for those reciprocal changes on there. More severe pump failure, and then high-risk complications, mortality. All right. So let's talk about posterior MIs for a second. I'm trying to think of a great way to explain it. The way I was trained, so you look at, like in your V1 through 3, you have ST depression, but the way I was trained is if you flip it upside down, and it looks like, it would then look like ST elevation in a pattern that has that sloping appropriately, then you might want to think about a posterior MI and getting those posterior leads on them. So here's our right-sided leads placement, and then we have our posterior lead placement on the back on the right image there. All right. Yes, EKGs are frequently misinterpreted. We never rely on the computer interpretation. It is helpful for like your rate and some of your measurements for your waves and your segments on there. But we still misinterpret them very frequently. Nowadays we have newer machines that are pretty good. And we do studies on this all the time with the latest AI that comes out, how well it translates versus like a ER physician reading them, and they're relatively close depending on what machines you have. But we also want to interpret ourselves because we can still miss quite a few things, and as you can see by the percentages, we do miss them. All right. We already kind of talked about when we get the right-sided and our posterior leads. Other concerning findings are that abnormal T waves in B2 and 3. So you guys remember Wellens sign? You have those hyperacute T waves or those large T waves, but you don't see any ST elevation or other abnormalities on your EKG. This correlates pretty well with critical stenosis, left anterior descending over the next 30 days. So these are patients we don't consider a STEMI, but it's something we need to deal with right now. So we will call the cardiologist for these, and it's something we need to identify on those EKGs. So what do we see on here? Yeah, it says Wellens at the top, sorry. Yep, so where do we see it? We see those like deep T waves in B2, 3, and 4. Most commonly in like B2 and 3 are where we're gonna see them. We also have some inversion as well in like 5. So this is something we don't call it a STEMI, but it is something we need to deal with sooner rather than later. So we do consult the cardiologist, and they'll likely get a catheter, or they'll evaluate all of it in the cath lab and check. But here's just general criteria for Wellens. One of the things that's important, like sometimes during the pain, they might not have those abnormal T waves. So this is something we might get repeat EKGs on when they're pain free to assess for it. And then you can have the deep symmetric ones like we saw in the picture, or you can have biphasic ones in some Wellens, depending on which type it is. All right, so cardiac biomarkers are important when we're evaluating chest pain. Troponin is going to be most commonly one used now. We used to use other ones, but we don't use them as often anymore. Like your CKMB. So for some reason at one of the places I moonlight at, they still have they automatically run it with the troponin. I don't know what to do with it most of the time, because I have a troponin there, but this is what we rely on right now, or the biomarker of choice. And we have high sensitivity ones, so it'll be dependent on your facilities for your delta troponins. Wherever you're doing phase 2, they may have the newer assay where you can rule out ACS without waiting 2 hours for your delta troponin, so you just gotta ask them when you're there. But for our purposes, it's 2 hours, we need to get a delta troponin to rule out an NSTEMI. And then some of the other labs we commonly get in these patients, CBC, CMP, BMP. We like to add MAG-FOS on there, and to check chest x-ray for all these patients. If we're thinking about, which we'll talk about in a sec, but on the take-home point side, we had anticoagulants in there. Sometimes we'll get coags as well, so PT and INR. All right, and like I just said, a single troponin is not recommended for ruling out NSTEMI if they present under 6 hours. So if it's longer than 6 hours, you can get one and usually rest relatively assured that it's not an NSTEMI. But we usually like to have 2 of those while they're in the ED, an initial and 1 2 hours later if they present under that 6 hour mark. And then this just shows your cardiac troponin starts to elevate within that 6 hour time frame, and then it kind of peaks at 24 hours, and then it starts to decline after that. So it is the best test we usually have for these, for diagnosing acute coronary syndrome. So when we're stratifying them, it's easy. If they got ST elevation, then we call it STEMI, call the cath lab. If not, we have to wait for our troponin, and then we have to decide if it's elevated, then we're gonna consider it a STEMI, and we're still gonna call the cardiologist. And then if you don't find anything on there, we're gonna look at the risk and call it unstable angina, and likely consult the cardiologist as well. And that's like what I just said. So troponin is the most sensitive specific test we have for cardiac necrosis or myocardial necrosis, and we got to get that repeat to make sure that if we weren't in that window yet, that they're not having an acute myocardial infarction or NSTEMI. All right, imaging, we want to get a chest x-ray so we can help rule out some of the other bad things, like I talked about at the beginning, that we're looking for. So like pneumothorax, it's not, you can't diagnose CHF from it, but it can be helpful looking for any CHF, cardiomegaly, any effusions, pneumothorax, we want to consider that. If we have pulmonary embolism or dissection, aortic dissection or differential, we'll get a CT of the chest, a CT pulmonary angiogram, or a CT of the aorta angio. All right. So here's our risk stratification. And this becomes important because I want to say like, I don't know, less than 5% or whatever. But it's a pretty low number. Patients actually have, an acute coronary syndrome when they present to the ER and we evaluate them for all of this and work them up. So the question is like, do I feel comfortable sending this person home? The good news is we have a validated risk stratification tool that's been studied over, thousands of patients. And we use what we call our heart score to risk stratify them. And so they get points for each of these categories, and we'll talk about how many points for each category, but one of them is going to be the history. Do I have any EKG findings? What's their age? What risk factors do they have, and is their troponin elevated? And depending on that score, we can comfortably stratify them into people that we think may have an acute coronary syndrome in the next 30 days, or they may have mortality from acute coronary syndrome. And which ones we can say they can get worked up and get a stress test, or we can further evaluate them within the next month. And here's how we look at it. So history, and as you can see, it's like kind of subjective, right? It's like slightly suspicious, moderately, highly, and that's what we're talking about. The initial history, like was it that classic crushing chest pain? Did they have any diaphoresis with it? That would make it more in the highly suspicious versus moderately versus slightly. Slightly suspicious is a lot of the ones that are just chest pain. It's been going on for 12 hours, 24 hours, so that would be 0 points on those. And then we look at the EKG, so they get a 0 if it's normal. If they have non-specific repolarization disturbance, we give them a point. And then ST depression gets 2 points, and if they're under 45, 64, and over 65, they get points added. Then we look at risk factors. So are they a smoker? Are they obese? Do they have hypertension, diabetes, hyperlipidemia? Then we just add it up. 1, 2 risk factors, they get a point. And then they get 2 points for 3 or more risk factors. And then we evaluate the troponin and how many upper limits of normal, how many times the normal limit it is. And then we risk stratify them, or we think they're going to have an acute cardiac event the next 6 weeks. So the important part is what the points at the bottom mean. So 0 to 3 is going to be a low risk, so less than 2% chance that they're going to have an acute coronary syndrome in the next 6 weeks or next month. So those patients are ones we can safely send home without patient follow-up, and they just need to see their PCM or a cardiologist, and they'll likely decide what they're going to do from there, whether they think they need a stress test. 4 to 7 points is moderate. So those are all those patients we're going to admit to the hospital. They're not high enough category where we need to, they need to go to the cath lab right now and actually take a look at all of their arteries, but they need to have some sort of risk stratification during the visit. So likely they'll get a stress test at this point. And 8 to 10 is going to be high risk. They're getting admitted as well, and we let cardiology decide whether they want to evaluate any of those vessels, which they'll likely take them to the cath lab, just not, in the next 90 minutes. All right, this is kind of what the treatment is. So like I said, STEMI, we need to activate the cath lab within 90 minutes or get them on our thrombolytic checklist, and transfer or consult cardiology to see how soon we can get them there, or transfer NSTEMI, still a cardiology consult. They'll likely won't go to the cath lab right now, but in the next 24 hours, they'll take them to the cath lab. And then treatment, everybody gets IVO2 monitor, and then we get aspirin and anticoagulation on anybody that's having acute coronary syndrome, and then nitroglycerin dependent on where that infarction is and whether their vital signs can tolerate it. And then we'll talk about how these meds and everything work in just a sec. But once again, here's a recap. So we have a little acronym, PCI. That's the meds we're giving for everybody there and why. So we want to stop the platelets, stop the coagulation, and then we're going to limit the infarct size. So aspirin, heparin, or we use heparin mostly. Lovenox may have a better profile, but better benefit and it's more effective, but unfortunately we can't turn off heparin, or low molecular weight heparin or low phenox, so we tend to stick with heparin because it's fast on, fast off. Alright. So once again, there's our goals for these patients: 90 minutes at the cath lab, 120 if you don't have one, and then fibrinolysis within 30 minutes if we're going to transfer and they can't get to the cath lab. And our preferred method is PCI for everybody, but sometimes that's not possible. And what we're going to do is place a stent in there. You can kind of see how the pictures look. So they go into where that thrombus is, and they place mesh in there or a little stent to help expand that area, so that we can reperfuse or get blood flow back to those arteries in that area of the heart that's been hit. And here's just some pictures of what a cath lab looks like. So they're going to shoot some sort of dye into those arteries, and you can see with the arrows on where the occlusion is, and then they get there by going up usually one of the radial arteries, and they just kind of insert that catheter all the way in to the correct area, and they shoot dye into it, and they find which vessel it is, and then they put a stent in there to fix it. All right. If it's not something amenable to the cath lab or to PCI, then it's usually multi-vessel disease, multiple arteries. So they'll do what we call a CABG or coronary artery bypass graft. So this is going to be like an open surgery. So they're going to do a sternotomy. It's a lot more intensive of a procedure, and this is normally done during that inpatient stay. So depending on how many vessels they find, they might have to do a CABG. All right. And here's what we do with the outlying hospital. We can't get them the cath lab 9 minutes. We give them the fibrinolytic checklist, and then give them fibrinolysis if we can, and then we transfer them. And then here's why fibrinolysis works. So it acts on the thrombus. There are studies showing benefit or short blood flow in 70 to 80%. It improves that left vent function and both short and long-term mortality. So that's why we use it. Unfortunately, it does come with risks, and mostly that's bleeding in other areas, since it's a fibrinolytic agent. So we can run the risk. The one we worry about the most is like a brain bleed in patients, just because of the neurological deficits that can leave them with, which is why we want to go through this checklist. All right, so here are, I think you guys had to know this with the first block too, right? Contraindications, fibrinolytics, they're the same. So, absolute contraindications. If they get a PCI, we don't need to give them fibrinolysis. If they've had a previous stroke, hemorrhagic stroke in the past year, known intracranial neoplasms, any sort of intracranial spinal surgery, or head trauma in the past 8 weeks, any active internal bleeding, or suspected aortic dissection, those are absolute contraindications. Everything else on the right is relative. So we kind of weigh the risks and benefits with the patient, and we can also talk, discuss how long it might be till we can get to the cath lab, and we may or may not give it in these cases. All right, and one of the nice things with fibrinolytics, how do we know it worked? So the patient starts to, they have improvement of their pain, is one of them. It's kind of cool in strokes when you give it and you see their whatever neurologic deficits improve. It's really disappointing when it doesn't, unfortunately. But they should be getting PCI anyway, so usually fibrinolytics aren't the only method we're going to use here. It just depends on how long until they get that PCI. And then, like I said, most catastrophic issue is going to be that like intracranial hemorrhage or brain bleeding leading to permanent neurologic deficits. That's why it's important we use that fibrinolytic checklist. And we also use shared decision making with our patient and explain to them what these risks could be if we give it. Yes, we can give you this with this, a very low risk of intracranial bleeding. However, it is a risk. Or if we don't give it, we run the risk of that lesion becoming completely occluded and that area, the crowsing, and you may lose cardiac function, heart failure, may lead to heart failure, or it may lead to death in a lot of cases as well. So we just want to make sure we give them all their options and let them decide. Take a 10-minute break, be back at 2 o'clock. Side platelets, so stop the platelets. And we usually give, they usually chew it, and we give them 324 milligrams. They come in 325s, but we give 481s for some reason. Not sure why, maybe, I don't know, maybe works better. We want to use, we want to stop that coagulation, so we use an anticoagulant like heparin, or we can use Lovenox. And that one we give like 60 units per kilogram, max of 4,000 units. I won't get technical, sometimes we do 5,000, depending on whether it's M-STEMI versus STEMI. I haven't had anybody told me to use low molecular weight heparin, but it certainly has a better, it's more effective, and has a better profile. It's not something we can turn on or off if we have complications, so we don't use it as often for ACS. Then we want to limit the infarct size with nitroglycerin if there's no contraindications. And then definitive treatment, they need that PCI. So pretty easy, right? Like almost everything, we need to get them to the cath lab, the cardiologist. Unstable angina, we still need to call the cardiologist. And then where it gets tricky, because less than 5% have a STEMI or ACS. So most of the time we're looking at normal EKGs and risk stratifying with our heart score. And then here's some medication overview that we'll talk about. So we give an antiplatelet agent, which is commonly aspirin. There are other ones we can give as well. So we can give clopidogrel or Plavix if they have an aspirin allergy, or we're worried about peptic ulcer disease or some sort of GI bleeding. We can give them Plavix. So aspirin alone reduces mortality in patients, which is why we give it. I mean, we tend to not withhold it, so anybody that comes in with chest pain, if I have any suspicion of ACS, even if they're young and I know it's not, I still give them aspirin immediately when they come in, just for the off chance that they can have an acute coronary syndrome. We don't withhold it for minor issues, like they had a peptic ulcer 10 years ago, or they had a GI bleed a long time ago, or vague allergies to medication, which you guys will become very familiar with, that everybody thinks they're allergic to everything, and you're like, that's not an allergy. You're like, I had my upset stomach after I took it. Okay, probably took it on an empty stomach or something. Probably not an allergy. Other antiplatelet agents, these will be initiated at the time of their PCI, but we have those glycoprotein antagonists, and they're better antiplatelet medications that we give them. So they'll give those right before the PCI. It's not something we're normally giving in the emergency department, unless the cardiologist, when we call them, they're like, oh, hey, push this, we're gonna take them right now. So sometimes you'll hear these used. And then we have our anticoagulants. So these are important. They reduce the risk of death, acute myocardial or progressing to myocardial infarction. They help in the acute phase unstable angina. And then in combination with, you have your antiplatelet and your anticoagulant, it reduces that short-term risk compared to aspirin alone. And then I already kind of said the dose, it can be variable, so it's important to know like 4,000 units, and then sometimes we use 5,000 depending on the patient, or sometimes your facility will have a policy in place where you push 5,000 as the max units instead of 4,000, but nothing to really wrap your head around. There's the low molecular weight heparin. It does have longer half-life, which is why we're hesitant with it, because we can't stop any bleeding if we have side effects from it, or we can't stop the medication's effects, but it does have a more reliable anticoagulant effect. So if your facility recommends this for the patients, then that would be something you talk with the cardiologist, and they're like, no, we use low molecular weight heparin, or Lovenox is the brand name. And then we want to limit that infarct size with our nitroglycerin or vasodilators. So these are helpful to increase myocardial blood flow, and they can help limit the size of that infarction. We just have to remember those contraindications to it, so hypotension, an inferior MI, or if they use like any of those PDE5 inhibitors, so like your Cialis, Viagra, all those ones, we want to avoid use in those cases. All right, and there's the mortality rate decrease, so pretty significant. You know, mortality rate's lower by 35%. You know, we can give them the ones that you dissolve under your tongue. We also have nitroglycerin paste we can give them, or most of the time we'll start a nitroglycerin drip in these patients and titrate it. Commonly we see hypotension with it, which is why we don't give it in hypotension, but you may see a reflex tachycardia, which is very rare, but those are side effects we want to consider to worsen ischemia and cause a paradoxical bradycardia, but you know, those are not super common. And then, like we said, inferior wall, don't give it. If, you know, it's usually pretty simple. If we see hypertension, we stop the medication. So usually pretty straightforward. We just have to make sure we get a good history that they didn't just take, which I think would be kind of odd. I haven't had anybody show up and I just popped my Viagra and now I got chest pain and I think I'm having a heart attack. So I haven't had that happen yet, but someday. All right, so we don't use beta blockers acutely in the emergency department. They do show a benefit, but it's not something we're going to use in the acute setting. It's going to be something beneficial in the first 24 hours after they get their cath. That cardiology is going to prescribe them. We just, you know, it has a high risk of the cardiogenic shock, so we want to avoid that in the acute period. Same with ACE inhibitors, so they do show benefit, but not acutely. And we used to give these. We don't do it anymore during the acute period, so usually they'll get it within the first 24 hours, but they'll get a cath first. And then we don't use calcium channel blockers. They don't show any benefit, and they show harm in the studies. And those are ones like verapamil and diltiazem are common ones we give in the emergency department for arrhythmias or AFib or other conditions like that. But we don't want to use those during acute coronary syndrome. And then complications, you know, from the STEMI or acute coronary syndrome. So there's a few of them that we worry about that are more common. I mean, there's a lot of them, but the ones we worry about the most are like a deadly arrhythmia, especially VTAC. They also have, they can have like a lower threshold for ventricular fibrillation. So we always want to keep these patients on a cardiac monitor while they're in the emergency department, just watching for one of these deadly arrhythmias. Like it says, like an anterior wall MI, you might see tachycardia. You might see like bradycardia with an inferior right vent. So there's just different syndromes you may see with it, but this is something we want to consider in all of our ACS patients. They can have mechanical complications, so we can have like papillary muscle rupture. We can have septum, free wall issues. And what's nice is some of these we can look at on our point of care ultrasound and evaluate if they're having any at the time. But if it does happen, they usually suddenly decompensate, and it is concerning. All right, so here's our ventricular free wall rupture. This one usually after the infarct, so like 1 to 5 days, you may have a patient that was recently discharged. They come back to the emergency department, and they're complaining of chest pain. This is something that we get concerned for, that they have some sort of rupture of the left ventricular free wall. These ones may have that like tearing chest pain. It's usually sudden onset, severe, and most of them are going to be sick, so they'll be hypotensive, tachycardic. And this is one we get an echocardiogram for, and they'll likely have to do some sort of cardiothoracic surgery for these patients to evaluate it. Cardiogenic shock. So this presents, we have like severe hypotension, and then you see signs of like that hypoperfusion. So, you know, they got those cool extremities, they're no longer producing urine, they may be altered. And then they can have respiratory distress. So when we see any like new or worsening hypotension, or we see a change in those vital signs during our evaluation or while they're there, this is something we need to consider. And then, we'll start with fluid boluses for that hypotension, and then we might add on like an inotrope like dopamine for them. All right, pericarditis. So Dressler syndrome is basically pericarditis following an acute coronary syndrome. So you have some sort of inflammation wherever that infarction was or on the epicardial surface. And then they present, with signs of inflammation, usually a couple days afterwards. Sometimes, it can be a month, but it's something we need to consider in the back of our minds. Anybody that had a recent acute coronary syndrome, which always can, if they're less than 3 months after a STEMI and they had a cath, I'm concerned, like from the get-go, that something could be going on. But luckily this one is just can be treated with medication. So you may have that pleuritic chest pain, worse with inspiration, better with leaning forward, all your typical characteristic findings of pericarditis, but it's just after a myocardial infarction. We don't like to use, so normally we can use NSAIDs on these patients that don't have any coronary artery disease or recent ACS, but we don't usually use like the Motrin and things like that for pericarditis in these cases. So this is something we want to look at colchicine and aspirin with, versus normally like in a younger, healthier patient, we can treat it with an anti-inflammatory, like Motrin works great, or ibuprofen. Like indomethacin is another one that works great for these. And then we can add colchicine in like a patient without a recent acute coronary syndrome, which we'll talk about in our next lecture, but one after that. And here's a summary. So, the presentation, do they have those risk factors that would increase the suspicion for acute coronary syndrome? So do they have that crushing chest pain? Do they have any sort of radiation to the jaw, arms, legs? Does it radiate to their back? And then we get our EKG. Do we see any findings on there? Is it normal? Do we have like ST segment or wave abnormalities, or is it STEMI? And then we look at the troponin, is it positive or not, and then we stratify them into non-cardiac, unstable angina, STEMI, NSTEMI, and then other cardiac causes on there. All right, so there's some pearls what we talked about. Get the EKG within the first 10 minutes. It needs to be read. We get our safety net. We usually draw a rainbow of labs. And then if we can't get to the cath lab, we need to do our fibrinolytic checklist. And then we need to find a cath lab for them, because that's what they're going to need for definitive treatment. And here's our take-home points, which we covered at the end. And I feel like I'm just repeating and beating the dead horse, but this is a recap of everything we covered today. Here's some some more study aids of where that MI might be, and then another one as well. Just make sure, I'm definitely going to ask, there's definitely going to be some STEMIs on your test, and then there will be, a question or two on which arteries involved, and then it's important to know the treatments we talked about in there. So there will be presentations of what are you going to do initially, what is your definitive treatment, how long do you need to get to a cath lab. So it's important to understand and know all of that. Then there will be, one or two on some of the complications. If it was up to me, I would just put like 10 normal EKGs in there, because people would probably do worse with it, but probably not helpful.
I'll just cry.
But those are the good ones. And then there's our reciprocal changes and what we're looking for, so our Pales mnemonic. All right, what questions do you guys have? Nothing? It's all very straightforward, hopefully. Yeah, it's a bad EKG on there. Not good. Well, I'll stick around if anybody has any questions.